Okay, let's talk about PE. First, what is it? What is a PE, or a pulmonary embolism? And that's what I will refer to, pulmonary embolism, on this PowerPoint and also throughout the semester, as a PE. So what is it? It's an obstruction of a pulmonary artery or one of its branches by a clot, more specifically a blood clot. Okay, so a PE is an obstruction of the pulmonary artery or one of its branches by a clot. This is just a picture of the pulmonary highway, the PE highway, of how it occurs. What happens is you usually have some type of trauma that would cause DVT or clot in one of your extremities. Lower extremities are more common. So we have increased coagulation that occurs, we have a clot, and then that clot gets dislodged and it travels back up to the heart. Goes into the right atrium, into the right ventricle, and eventually it makes its way to the lung. And once it gets into the lung, that's where it causes all of our problems, because it blocks off any blood that's going through, the transportation, the oxygen exchange. Nothing like that can occur there. So this is what usually happens. It starts out in one of our lower extremities, it breaks loose, and it goes to our lung. Causes of PEs. There are many different things that can cause it. The one that we mainly talk about are blood clots, the ones in our lower extremities that I've already mentioned to you. That's the big one, DVT in our lower legs. There are other causes of PEs, fat emboli being one, air emboli. You guys learn about that in IV therapy when you talk about central lines. You'll learn more about that, but the patient can have an air emboli. It's life-threatening. Amniotic fluid, that's for pregnant women, and I believe that's during labor. Amniotic fluid can actually escape and cause a PE. Any foreign objects, okay. Had a patient once that had an IV cannula stuck in his arm, and he had to go in and have that removed. But had that have traveled from his lower forearm up to his heart, then he could have been in some serious distress, if not death, or any injected particles that goes into the body. All right, so those are causes of a DVT. This is just a picture again of a pulmonary embolus, showing you all the different things, showing you the clot there at the bottom and how it travels on up, gets into the lungs. Patients who have PEs are normally on an anticoagulant, and this picture shows heparin up there, which is an anticoagulant. Usually when they have a PE, they do have a sudden sharp chest pain, so that's one of the symptoms that you may see. They're going to start breathing faster. They're going to have a low PO2. They're going to be hypoxic. They're going to be short of breath. Their heart rate's going to go up. It would not be uncommon to see bloody sputum or hemoptysis. Okay, so these patients are normally on heparin drip. They usually have IV lines going for fluids. When we look at their ABGs, we're going to see decrease in our CO2, a decrease in our oxygen, definitely in our oxygen, and an increase in our pH. So remember, I told you, you are never going to get away from ABGs, so we have to learn them. So we're going to talk about ABGs with this. I don't know if you guys remember seeing this story on the news a few years back. It's a story. His name was David Bloom. He is actually a reporter or a journalist, and he was in Baghdad. He went out with the military when they're out in the field, and he went out there. He actually had come back in, and he was complaining of pain below his knee. And what had happened, and he was in a tank, or it's my understanding that he was out in a tank. And if you can imagine being in those tanks, they're all hunkered down, they're all squatted down for several hours at a time. So he didn't have any activity with him. So he was all hunkered down in there. Actually, when he came back, he did actually call the medic or medical personnel, and they told him, he described his symptoms, that he was having pain in his lower leg and what had happened. And they told him that he needed to come in because it sounded like a DVT. But instead of going in, he ignored them, threw his backpack on, went on out, and it broke loose from his lower extremity and actually went to his lung, and he died. So had he had gone in to see the medic or someone who could help him or assess that DVT, then he probably would still be alive, but because his job took him away from seeking medical service, he did die. Death is usually within 1 hour of the onset of symptoms once you have a PE, so it is extremely important that we have early recognition of a PE. So if you think that you may have a DVT or a clot in your lower extremity, you want to get it checked out and you want to start treatment, because you sure don't want that to break loose and go to your lung and become a PE. Diagnostic studies that we're going to see with a PE, rule out exams that you're going to see. They're going to do a chest x-ray. Is that going to really tell us? Well, no, not really, but it is going to help to rule out other causes of the symptoms that the patient is showing. EKG, on an EKG, if your patient has a PE, a lot of times you will see a T-wave inversion. D-dimer test, that's the test for clots, and that will tell you, now it's not definitive, but a D-dimer, when they suspect that, will come back and tell you if it's a high probability or a low probability, and then further tests will be done beyond that. Diagnostic exams that we actually use are the VQ scans, the ventilation perfusion scan, right? It's just comparisons from the ventilation and the perfusion in different areas of the lungs. That's how they do that. A lot of times you'll see a spiral CT scan. Okay. The difference between a spiral and a normal CT scan is what they can see. It's the difference between, I believe, 1 millimeter versus a 5 millimeter. You know that CTs, it slices the pictures of your body as it goes through. And so this shows a much thinner slice, so we can get a better picture of that. So that's why you'll see a spiral CT scan ordered. And ABGs. And even though you have a PE, your ABGs can still be normal in the initial phases of that. So you probably would want to check those again if you're still suspecting those. The best thing that you can do are a pulmonary CT. That's not always feasible. So these other scans are what we would want to do to look for the PE. Okay, so let's look at this question together. The nurse enters the patient's room and finds the patient is experiencing shortness of breath, an O2 sat of 88%, the respiratory rate is 30, it's labored, the breath sounds are decreased, and they have crackles in the bases. Oxygen's on at 2 liters per minute per nasal cannula. Which of the following actions would you do first? So I want you to push pause on this PowerPoint. I want you to read these responses, get the answer in your head, and then I want you to push play again and see if what I'm going to tell you is what you actually chose. Alright, so hopefully you have read the answers to this question. Our goal is we want to prevent PE, and mainly to prevent a PE, we want to do that by preventing DVTs so that the DVT can't travel to the PE. With this patient, our goal is the first one. Our goal is to immediately stabilize our cardiopulmonary system. That's what we want to do, immediately stabilize that. And how do we do that? Raise the head of the bed and increase the oxygen to 4 liters per minute. Now, these other things on here, are you going to put the patient in a prone position? Well, what's prone? That's on their stomach. Is that really going to help them? No. Are we going to complete a head-to-toe assessment? We have completed a focused assessment just by looking at this assessment data in the question. So if we believe that a patient has a PE and we've got this focused data, we're not going to take the time to do a complete head-to-toe assessment before we address the respiratory issue and get more oxygen in there and increase the oxygen being administered. And would you give morphine? You may possibly give morphine, but I'm more worried about getting oxygen in them than I am morphine at this point. So hopefully you all got that correct. This is a picture of an inferior vena cava filter, and if a patient is at high risk for developing subsequent PEs, then they will put this filter in, and it goes in the inferior vena cava. This is kind of what a picture looks like, and just think of it as like a colander in your kitchen. It strains the blood as it comes through, and if there was a DVT that was to get that far in your system, hopefully that filter would stop it right there, and so it would not be able to go on through to your heart and lungs. Okay, so let's talk about general medical management. Anticoagulation therapy, we're talking about a blood clot, so it would make sense that we need something to try to prevent that. And heparin is what we would usually use, and hopefully by now you know that in order to monitor heparin, you're going to monitor a PTT, and with our Coumadin, it's the PT-INR. If I have a patient who is on heparin, it would make sense that they would be at risk for bleeding. So we need to think a little bit about bleeding precautions. And whenever we look at our patient, what are we going to see? So you need to stop this, pause it, and just on a piece of paper, jot down what you think as the nurse you would assess your patient and see. And then turn it back on and see if you are correct. Okay, so hopefully you jotted down a couple things and you came back, and some of the things that you came up would be petechiae. Okay, so we may see that if we have a patient who is bleeding. You may see bleeding gums, you may see bleeding at puncture sites where we have stuck them. When we think about the heart or the cardiovascular system, things that we may see, hypotension. Why would we see that? We would see hypotension because think of it this way: if I have no vascular volume, if I'm bleeding out somewhere, then I have no volume, I can't keep my pressure up, so therefore it would go down and I would see hypotension. My heart can't keep up, or is trying to keep up, and so it would increase its rate. Therefore you would see tachycardia, you would see dizziness, you may see nosebleeds, patients go into respiratory distress, you would see fast breathing or tachypnea. Hemoptysis, if they're bleeding into their abdominal cavity, you may see abdominal distension, rectal bleeding, vaginal, urethral bleeding. Neurologically, you may see mental status changes. That would be the big thing: blurred vision, headaches, things like that. So hopefully whenever you thought about that, those are some of the things that you would come up with. Laboratory testing, we always want to monitor CBCs and our platelet levels. You guys need to know what a normal platelet level is, so if you don't, you need to go back and review that. Making sure that if our platelet levels are low, we know that our patient could be at risk for that. We may have to test their urine, their emesis. We may also be doing stools for occult blood. Okay, so nursing interventions. Again, pause this slide and think about it. I'm the nurse. I'm taking care of this patient, and I'm trying to prevent complications with the patient with bleeding precautions. What am I going to do? Pause it, write some things down, bring it back on, and see if you are correct. Okay, so hopefully some of the things that you came up with were do not give IM injections. Okay, we know we're poking a hole in somebody who's at risk for bleed. Would that make sense? Of course it would. Avoid giving medications like aspirin, anything that's going to inhibit platelet function. We don't want them bleeding. You would avoid catheters if at all possible. Don't take rectal temps, no suppositories or enemas, because we know that can make them at a higher risk for a bleed. We would, however, want to use stool softeners or other laxatives to prevent the complications of constipation. Okay, we always want to use the smallest needle possible, and we would apply pressure longer than we normally would to venipuncture sites. No, we recommend no flossing of the teeth, and to use only soft bristle toothbrushes for our mouth care. And a lot of times the hospital have those little green toothette things for patients who have low platelet counts, and we are concerned about that, so we would use those little toothettes instead of actual brushing so that we don't cause bleeding at the gums. Make sure that we're lubricating their lips and we're doing good oral care. We try not to suction if at all possible, but if we do, we want to make sure that we're doing it gently. We're not getting in there and really vigorously doing that. Trying to prevent the patient from vigorously coughing, really blowing their nose, anything that could cause bleeding. Electric razors, we want to make sure that they're not using a straight blade to shave, so we want to take precautions with razor with shaving. That is really big with our male patients. And then we would always want to try to prevent falls if at all possible, because we know falling, and if there are bleeding precautions, we're going to have a much higher risk of complication if that were to happen. So hopefully some of those were the things that you thought about whenever you thought of, as the nurse, what am I going to do? Now, what are you going to do to control the bleeding if it does happen? We always want to apply direct pressure. That's what we want to do to control the bleeding. For example, if we had a nosebleed, then we usually put direct pressure there to the nose. You would put them in a high Fowler's position. You would usually use an ice pack and apply pressure, and you would again let the physician know if you felt that your patient was bleeding out, or obviously if you could see it that it was bleeding out, the physician has to know, and you would probably end up giving platelets, FFP, or fresh frozen plasma, or possibly a unit of blood or packed red blood cells is what you would probably end up giving at whatever your doctor decided to give. So those are the types of things that you need to worry about with a patient on bleeding precautions. Now, back to the heparin and the Coumadin with a patient that we're trying to regulate here. Your thought process should be this: I have a patient who is on heparin, but they're also receiving Coumadin. Do I know why this is occurring? So think about that, and then come back and answer this. And I hope that you're able to understand that in the hospital, heparin is given IV. We can't send someone outside the hospital. Here's your pole, here's your bag, enjoy the day. So we have to give them something else. So we give them heparin in the hospital. We start them on Coumadin. Coumadin has to be therapeutic in our system. So while that Coumadin is becoming therapeutic, the heparin is doing the job for us. Once the Coumadin becomes therapeutic, we can remove the heparin, let them go home with the pill that is going to help them, and then they'll get their labs checked frequently to check those INRs to make sure that the Coumadin is remaining therapeutic. But that is why your patient is on heparin and Coumadin at the same time. On your slide there, you'll see a chart that you'll need to review, and that is for Coumadin teaching with your patient. For therapeutic on your INR, the lab value that you need to know is 2.0 to 3.0. So if you have a patient who is on Coumadin, the therapeutic range that we want is 2.0 to 3.0. When we talk later in the semester about valves, we're actually going to increase that level. But in general, other than a valve patient, the therapeutic level is 2 to 3. Also, a couple other things that you may see used are drugs that are such as Arixtra and Lovenox, which is low molecular weight heparin. But instead of a continuous infusion, these are given by subcutaneous injection, and they're actually used quite frequently for smaller PEs, and you'll see those in the hospital. But you need to be familiar with those two drugs and why your patient would be receiving those. All right, we just talked about anticoagulation therapy with the heparin and the Coumadin. So now we're going to talk about thrombolytic therapy. This is usually for a much larger PE and also within our time frame. The drugs that we're going to talk about with this is urokinase, streptokinase, and the alteplase. Thrombolytic therapy are clot-busting drugs. So heparin does not bust up a clot. It prevents the body from forming any further clot so that our body has time to absorb the clot that has already developed. With the thrombolytics, it actually busts up that clot. Obviously, the big side effect with this one again is going to be bleeding. In your book on page 602, you'll want to review that for the contraindications, lab value assessment, and the use of anticoagulation. We're also going to do case studies in class to review these, so you'll become more familiar with them. Things that you'll want to watch for, and this is in your book: patient who's had a CVA or stroke within the last 2 months, if they've just delivered a baby recently, and surgery, I believe, within 10 days. Those are 3 big contraindications for thrombolytic therapy. And there's a few more that you'll look at in your book. And again, we're going to work on this in class over a case study.